Welcome to the Pharm.D, Bridging the Gap Between Science and Practice, Train-to-Trainer session for Oncology 1, Solid Tumors. This is Thursday, August 26, 2010. This presentation is supported by a grant by the Centers for Disease Control and Prevention. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of CDC. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Today's agenda includes an overview of the Pharm.D program, review of the educational content in oncology, future webinar dates, contact information, survey instruments, and a question and answer session. All copyrighted content included within this presentation has been granted copyright permission. No part of this presentation can be reproduced in any form without permission of the rights holder. The overall objective of the Pharmacogenomics education program, Bridging the Gap Between Science and Practice, is an evidence-based pharmacogenomics education program designed for pharmacists and physicians, pharmacy and medical students, and other healthcare professionals. The overall objective of the Pharm.D program is to increase awareness about current knowledge of the validity and utility of pharmacogenomic tests and the potential implications of benefits and harms from use of the tests. We have the following educational modules available as part of the shared curriculum for faculty. The webinar dates for these sessions will be provided at the end of this presentation. In the following discussions of each therapeutic area and the pertinent pharmacogenomic tests, the information will be presented in the following format: the gene and/or allele of interest, functional effects of the gene and/or allele, prevalence rates of the gene and/or allele variant in different populations, the available genomic tests, summary of the most clinical data available to the date, and this information is further organized into literature that affect dosing or drug selection, those that affect efficacy, and those that affect toxicity. And finally, recommendation for genomic testing from reputable agencies or national guidelines. At this time, we would like to introduce the author for Oncology 1. Dr. John Valgus is a clinical pharmacist practitioner at the University of North Carolina Hospitals and Clinics and an assistant clinical professor at the UNC Eshelman School of Pharmacy. He is a director of the Hematology Oncology PGY2 residency at UNC Hospitals. He is also a member of the UNC Institute for Pharmacogenomics and Individualized Therapy. He received his Bachelor of Sciences and Doctor of Pharmacy degrees from the Philadelphia College of Pharmacy. He completed his pharmacy practice and hematology oncology residencies at the University of North Carolina Hospitals and Clinics and completed a fellowship in clinical pharmacogenetics at GlaxoSmithKline. He is a board-certified oncology pharmacist, and his research and practice interests include supportive care in cancer patients and implementation of personalized medicine. Please help me welcome Dr. Valgus.
Thank you, Kelly. It's a pleasure to be with everyone here today, and I see some familiar names on the participant list, so I'm glad to see some of those familiar names. And this is a topic that definitely is near and dear to my heart. It sort of combines my two passions of taking care of oncology patients and trying to figure out this whole individualized therapy thing and how we can best deliver it to our patients in the clinical setting. As far as learning objectives for today, learning objectives include identifying specific drug therapies used in which pharmacogenomic testing can be applied in the clinical setting. We'll also summarize evidence-based recommendations for pharmacogenomic testing and use patient case scenarios to formulate a plan for pharmacogenomic testing based upon available scientific evidence. So in choosing the topics to include in this particular presentation for solid tumors, I think there was a number of options that I could have chosen. But I've chosen to focus on three in particular, including Irinotecan and the UGT1A1 gene and its role in predicting the toxicity with Irinotecan. We'll also be talking about epidermal growth factor receptor inhibitor therapy, mainly cetuximab and panitumumab, and the role of KRAS in predicting response to these agents. And finally, what I think is probably one of the most controversial areas within the solid tumor world in pharmacogenomics is the role of CYP2D6 testing and tamoxifen in prediction of outcomes in patients with breast cancer. So let's begin with Irinotecan and UGT1A1. So I thought we would introduce the concept with a patient case scenario for each of these different subtopics. And here we have a 55-year-old male with a newly diagnosed stage 4 colorectal cancer. His oncologist goes ahead and orders a UGT1A1 genotype and finds that the patient is homozygous for the UGT1A1 star 28 polymorphism. So the question is, how would this information change your recommendation for irinotecan use and dosing? So I think all good pharmacogenetic examples usually begin with the drugs themselves and a little bit of discussion about the pharmacology. So irinotecan in general is a camptothecin class of topoisomerase inhibitors. We use irinotecan in a variety of malignancies, but probably the two most common areas that we see irinotecan used is in the colorectal cancer setting, either alone or in combination, more commonly with other chemotherapy agents. It's also used in combination with cisplatin or other platinum agents in small cell lung cancer. One of the things that we know about irinotecan is that it's associated with some significant side effects. And for those of you who have been around long enough to know the old chemical name for irinotecan being CPT11, there's sort of an old joke going around that CPT really stood for can't predict toxicity. And hopefully this example can show we're a little bit closer at predicting that. As far as the significant side effects that are included, probably most notoriously with irinotecan is severe diarrhea. And I think in oncology we like to use plays on words and things like that. So some people, instead of saying irinotecan, used to say I ran to the can because of all the diarrhea associated with this agent. But it's definitely more than your just garden variety diarrhea. There are actually a few very large clinical trials in colorectal cancer patients that showed increased mortality in patients who had received irinotecan-based therapy and actually linked a significant percentage of those deaths to the complications of severe diarrhea. So it's definitely a very important complication. Another thing that isn't so uncommon across the board with chemotherapy agents is myelosuppression, in particular with irinotecan, the incidence of neutropenia. Also with irinotecan, we do see vascular syndromes as well. So in this slide we can see a couple different things. One is the standard metabolism of irinotecan. It is a prodrug that needs to be activated to SN38, which is its active metabolite and also the toxic metabolite. And you can see that right here. Then that active metabolite is inactivated through UGT1A1, you can see here. And if you relate this back to the patient case, there was an issue there at the UGT1A1 gene. What UGT1A1 does is inactivate SN38 into SN38G, which is then excreted in the bile. And the reason this is important is, as with most of our chemotherapy agents, has a very narrow therapeutic index. And so even with an increase in accumulation of active metabolite SN38 in patients who may not metabolize this agent well, one would expect maybe some increase in efficacy of the drug, but also commonly what we see with many of the other pharmacogenetic examples is you also see an increase in toxicity. What you see over on the right-hand side is the genetic abnormality that is responsible for decreased metabolism through UGT1A1. And basically what you have is an extra TA repeat in the promoter region of this gene. So you have 7 tandem repeats versus 6. And as you can see here, when you have 7 repeats, it leads to reduced gene expression, which then leads to lower glucuronidation, which in turn will lead into an accumulation of the active metabolite and presumably an increase in toxicity, which could include both the diarrhea and leukopenia. as opposed to normal patients who have the wild-type genotype. These patients have an increase in gene expression, normal glucuronidation, and presumably better tolerance for the drug. So this is, I think, an extremely important part of trying to educate students, because this really is the heart of the entire matter in terms of leading up to the increased toxicity that we'll see. So I think it's important to emphasize the specific gene involved, the specific polymorphism that is most notably recognized being the star28 polymorphism. And that does reduce the effect of UGT1A1 and reduces its transcription and enzymatic activity. Again, this leads to the reduced clearance of SN38, which is both the active and toxic metabolite. And one thing I think is interesting to note is that this was not the first time that people had come across this star28 polymorphism. It's also been seen in a syndrome called Gilbert syndrome, which results in a benign hyperbilirubinemia in patients. And this has led some institutions that I've talked to make the decision that maybe we shouldn't screen all patients for this polymorphism before they're receiving irinotecan, but maybe those patients who have a moderately elevated T bilirubin. And so I think that is still a controversial practice, but I know that there are some clinicians out there who really link these to the hyperbilirubinemia that's seen when you have the star28 polymorphism, and linking that to which patients may be screened. Now when you look across various populations, you can see that there is a bit of a difference in terms of frequency of the different genotypes. You can see in Caucasian individuals, about 13% of individuals are homozygous for the star28 polymorphism. You can see a little bit lower incidence in the Asian population of about 5% who are homozygous for the star28 polymorphism. And there are a few different things out there in terms of frequency in African Americans, but in general it's right around 20% incidence for patients who are homozygous for the star28 polymorphism. So I think one thing to take away from this slide is that it's a relatively common incident in our patient population in both African Americans and Caucasians, and 5% in Asians, where you may see the effects of this polymorphism. Now I think the real evidence behind if we should be screening or not screening lies with the clinical correlation between genotype and the toxicities of interest. And so I've listed here in this table a summary from the EGAPP group, which is the Evaluation of Genomic Applications in Practice and Prevention. And what they did is summarize a number of clinical trials to try and give some associations between clinical effect and genotype. And if you look again to those patients with the star28 polymorphism in this column, you can see the incidence of severe neutropenia was approximately 38%, versus those patients who are heterozygous for the mutation, only 18%, versus those patients who had wild type star1, star1, only about 10% incidence of severe neutropenia. They also looked at severe diarrhea and didn't see as strong of a correlation, about 27% in those patients with the star28 homozygous genotype. Same incidence in the population who are heterozygous, and about 18% in those with wild type genotype. I think another interesting fact that they included was tumor response. And they saw in patients who are homozygous for the star28 polymorphism about a 70% response rate with irinotecan. And when you look at those patients who are heterozygous or wild type, you can see a response rate of about 40 to 45%. Now I think this is an interesting piece of information, and definitely when you think about the pharmacology of the drug and possible accumulation of the active metabolite, you can see that this would make sense. I think one thing definitely to keep in mind is that tumor response is just one outcome that we may look at in terms of efficacy for our clinical trials, but many would argue that a more relevant response or a more relevant outcome would be progression-free survival or overall survival. And I've seen conflicting results in terms of star28 genotype and those various outcomes. So with this data, back in 2005, it led the FDA to actually change the package insert to include information about the star28 polymorphism. And I've cut and pasted the section on that here for you directly from the product information. And so I think this causes a little bit of controversy in itself, because now you do have an FDA statement at least acknowledging that the star28 polymorphism can lead to an increased risk of toxicities. And if you look at the actual recommendations made by the FDA, you can see that they say when administered in combination with other agents or as a single agent, a reduction in the starting dose by at least one level should be considered for patients known to be homozygous for the star28 polymorphism. And they do sort of add another statement that says the precise dose reduction in this patient population is not known, and subsequent dose modification should be considered based on individual patient tolerance to treatment. And so, this lays the landscape of possibly, should clinicians be genotyping? If you read into the details, they actually do not say to genotype all patients prior to receiving irinotecan, but if the genotype is known, they do make a recommendation for a dose reduction. And if you look into the product information, a one-level dose reduction is about a 15 to 20% dose reduction. So at the pretty much exact same time, the FDA also approved a test that still has one of my favorite names of all times for a diagnostic test, the UGT1A1 molecular assay. This was approved in August of 2005. It supposedly has 100% accuracy compared to DNA sequencing, a very quick processing time of 4 to 5 hours. This was the first commercially available test, but however, right now there are several commercial tests that are readily available. So when you look at the EGAPP working group recommendations, they do highlight, and others have highlighted, some of the pros and cons on either side of the debate in terms of to genotype or not to genotype before initiating irinotecan therapy. And when you look at those on side of genotyping, you can cite that there definitely is a very strong association with dose-limiting toxicities, namely the neutropenia. We do have a commercially available assay, so if you want to test, there is a commercially available assay to use. We know that the polymorphism is common in the general population, so like we had highlighted, anywhere between 5 to 20% of patients or so may be homozygous for that polymorphism. And you do have a governing body such as the FDA making a recommendation that they did for dose reduction in patients who are homozygous for the star28 polymorphism, which is included in the medication's product information. Now when you look at the other side of the argument, one of the things that I think is extremely important to think about is, well, when you look at the toxicity data that I highlighted in the previous slide, only about 30 or 40% of patients who are homozygous for the star28 polymorphism suffer severe toxicities. Now granted, that was much higher than other genotypes, but in my mind what that leaves open is that other 70 to 60% of patients who may tolerate irinotecan relatively well. And so if you're going to genotype patients up front and empirically do a dose reduction, one of the fears is that you may be doing dose reductions in patients who otherwise would have tolerated the drug, and one of the consequences of this may be that you actually decrease the efficacy of your therapy. Another controversial point was the dose recommendation by the FDA, being that 15 to 20% dose reduction. Many people highlight that that dose reduction has not prospectively been studied. It's mainly based on some of the PK modeling they had done from previous studies. And so we really don't have a study that randomized patients to genotype-guided dosing versus standard dosing, and measuring whether or not, number one, we maintained our efficacy or even reduced toxicity. Another argument that's commonly used against the genotyping for irinotecan is the doses that we use commonly in clinical practice versus the doses that were used earlier on in the use of irinotecan. Many of the studies cited in the EGAPP working group and in many of the early reports use much higher doses of irinotecan. I've listed some dose ranges here for you. So higher doses meaning anywhere from 200 to 350 milligrams per meter squared. Now when you look at more modern chemotherapy regimens, that dose is pretty rare. If you look at some of our more traditional regimens, for example, FOLFIRI in treating patients with colorectal cancer, or patients who are receiving this therapy for small cell lung cancer, you're looking more commonly at doses in the range of 100 to 125 milligrams per meter squared, or even lower than that. And when you look specifically at patients receiving these lower doses, some people argue that the association really begins to dwindle a bit between genotype and severe toxicities. So what was the official stance of the EGAPP working group? Well, it looks like they're a bit on the fence, and I think it's rightfully so. They state that evidence is currently insufficient to recommend for or against the routine use of UGT1A1 genotyping in patients with metastatic colorectal cancer who are treated with irinotecan. And the main piece of information that they cite is that there was no interventional trials showing that targeted dosing of irinotecan based on genotype would reduce the rates of adverse events. And again, I would also highlight and also demonstrate that you can maintain the efficacy of the drug. So that's where we are right now with the whole irinotecan story. But I think another thing that is important to highlight is really to think, well, what if we used this information earlier in the development of this drug? Would it have changed anything in terms of how we use irinotecan? And so some of the things I had highlighted earlier is that standard dosing of irinotecan in one of our most common regimens where it's used is determined to be about 180 milligrams per meter squared. Now when you came up with the dose-finding trials for this particular regimen and dose, one could assume that there were star 28 polymorphism patients in that group. And so the theory is that if they were included in those trials, could they have altered what our maximum tolerated dose would have been? And so the question is, if you excluded these patients from previous dose-finding studies, would your maximum tolerated dose have differed? And this is sort of the premise for a trial that was published a little bit earlier this year in the Journal of Clinical Oncology, which I thought was fascinating, where they actually screened patients for genotype. They excluded patients who were homozygous for the star 28 polymorphism. And then they did a dose escalation trial with the FOLFIRI regimen. The starting dose that they used was 215 milligrams per meter squared. And what they found is the maximum tolerated dose in patients who are wild type was 370 milligrams per meter squared versus a maximum tolerated dose for those patients who are heterozygous, about 310 milligrams per meter squared. Now keep in mind that the current recommended dose is 180 milligrams per meter squared, which is considerably lower than either of those maximally tolerated doses. And so I think this is something that I include not to say that we should be doing this in clinical practice, but I think something for food for thought of the power of using pharmacogenomic information early in the drug development process. It would be interesting to see if we had done this and follow these studies out to look at efficacy of the FOLFIRI regimen with these higher doses to see if it would be even more beneficial to patients while minimizing toxicity. So in summary, with UGT1A1, genotype definitely is associated with toxicities. Mainly the toxicity of interest is the neutropenia. Also a slight association with the diarrhea, however not as strong as association. And I think everyone would agree that prospective genotype-guided dosing trials with irinotecan are definitely needed to really confirm or deny the benefit of genotyping in this setting. So let's go back to the case. So SK was homozygous for the UGT1A1 star 28 polymorphism. We know and we could tell the patient that this does put the patient at significantly higher risk of severe neutropenia, possibly higher risk of diarrhea, but we can't say that with as much confidence. And although empiric dose reductions may reduce a risk, I think we also have to consider that it may also compromise the efficacy of our therapy. And so I think giving the patient a balanced piece of information is important in terms of this debatable issue right now. So let's move on to a topic which I do not think there's much controversy with at all, and that's to look at EGFR inhibitors and the impact of KRAS. So once again, let's start with a little bit of a case scenario here. So KG is a 58-year-old female, recent diagnosis of metastatic colorectal cancer. She's told that her tumor will be tested for KRAS to help determine the best chemotherapy regimen for her. The results return that she has a KRAS mutation in codon 12. And the question is, how should this influence the selection of therapy for this given patient? So one thing that's definitely important to note with the KRAS story and EGFR inhibitors is most of the data focuses on monoclonal antibodies which are currently approved to treat metastatic colorectal cancer. And I think the 2 points of emphasis is the monoclonal antibody part and the patients with colorectal cancer. Much of the data that I'm about to share has not been duplicated or been proven in other types of EGFR inhibitors such as the tyrosine kinase inhibitors, and also has not been proven in some of the other disease states where we may use even these monoclonal antibody EGFR inhibitors. So the two particular drugs of interest are the two that are on the market right now, so being cetuximab and panitumumab. These agents bind to the extracellular EGFR domain, leading to the inhibition of downstream signaling. Only about 10 to 20% of patients, when you look at the majority of clinical trials, actually benefit from anti-EGFR therapy. We've already looked at other areas that may help predict response, and EGFR expression does not correlate with clinical benefit in this patient population. But one of the issues we know with these monoclonal antibodies is EGFR is just the start of the cascade. And you can see the signaling cascade below EGFR, which includes RAS, BRAF, PI3K, PTEN. These are all active components which eventually will lead, we hope, to tumor response. And even if you have a normal EGFR expression, if you have issues in that signaling cascade below the point of contact, it does have the potential to interfere with the efficacy and the mechanism of your drug. So what exactly is KRAS? Well, KRAS is a downstream effector of EGFR. It belongs to the gene family of oncogenes encoding for guanosine ditriphosphate binding proteins. And we know that it's associated with control of cell growth, differentiation, and apoptosis. As far as the functional effect, activating mutations in KRAS result in activation of downstream signaling pathways and confers resistance to inhibition of cell surface receptor tyrosine kinase, such as EGFR. Now, when you look at the population prevalence of KRAS, particularly in colorectal cancer patients, you see it range anywhere between 27 and 43%. And I think it's important to keep in mind, as opposed to the previous example we were using, here we're actually genotyping the tumor sample, not taking blood samples or cheek swabs from the patient. And this 27 to 43% range is across several different clinical trials. So as far as the clinical relevance of this, one of the earliest trials to demonstrate the impact of KRAS in these patients with metastatic colorectal cancer was done back in 2006. They looked at a total of 30 patients. They found the KRAS mutation in about 43% of tumor samples. And when you look at their efficacy outcomes, they stated that 37% of patients in general had responded to cetuximab therapy, so 11 of 30 patients. When you look at KRAS mutation status, there were no responders that had the KRAS mutation, so 0 out of 11. As opposed to that, 68% of non-responders had the KRAS mutation, or 13 of 19. So what you could take away from this is the hypothesis that basically if you have a mutated KRAS, your chances of responding are very low, basically in this trial non-existent. Now, KRAS doesn't explain all of our non-responders, and that's where the 68% comes in. So we know that there is information out there in terms of other pathways, other reasons why patients may be resistant to monoclonal antibody EGFR inhibitors, but definitely KRAS predicted a big percentage of that population. What I've highlighted here is a couple of trials that looked at monotherapy with anti-EGFR monoclonal antibodies, one study with panitumumab and the other with cetuximab. The reason I've broken this out is often these agents are used in combination with conventional chemotherapy, and I'll show you some of that data in the next slide. But what they found in these studies basically was they were comparing anti-EGFR therapy to best supportive care in these metastatic colorectal cancer patients. And what they found in both trials, when you look at patients who had the KRAS mutation, is that there was no difference in progression-free survival, overall survival, or overall response rate. So the take-home point from this is that administering these therapies in patients was no better than simply administering supportive care for them. This is a collection of trials that evaluated KRAS in patients who received combination chemotherapy with a monoclonal antibody EGFR inhibitor. And you can see very large numbers of patients. You can see a variety of combinations with different types of chemotherapy. But one definite thing you see pretty much across the board is that patients did not benefit from the addition of the anti-EGFR chemotherapy. And so you either see no difference in terms of progression-free survival and overall survival, or in many cases you even saw a worsening, which makes many people wonder if that's related to an adverse effect of administering the drug, or if it is something inherent within colorectal cancer patients where they may be set up to do worse, and I think that's yet to be determined. But across the board, you definitely can say that patients who receive anti-EGFR therapy, even in combination with chemotherapy, if they're KRAS mutated, they are not going to benefit from therapy. So in summary, colorectal cancer patients who have a tumor that's mutated KRAS have a low likelihood of responding to anti-EGFR monoclonal antibody therapy. I did want to point out that in terms of toxicity and dosing, to my knowledge there is no data looking at anti-EGFR therapy and toxicity in relation to KRAS, and also no data currently available looking at if you would need alternative dosing in patients who have the mutated KRAS. So as far as if a test is available, the FDA did update the prescribing information to recommend against the use of EGFR inhibitors in KRAS mutated tumors. I will highlight again that this is a tumor tissue sample that's being evaluated, and there's multiple commercial assays available for KRAS that clinicians can use currently. So probably one of the most powerful groups in oncology is the American Society of Clinical Oncology. And last year they came out with what was called a provisional clinical opinion on this very matter. And it was very interesting because usually ASCO, at least in some of the other examples in oncology of pharmacogenetics, really don't come out with clear statements of what to do. But I think this leads to the non-controversial nature of the data around using KRAS. So basically what ASCO had stated is that all patients with metastatic colorectal carcinoma who are candidates for anti-EGFR antibody therapy should have their tumor tested for KRAS mutations. And if they do have mutations in codons 12 or 13, then these patients should not receive anti-EGFR antibody therapy as part of their treatment. So in summary, most trials only show about a 10 to 20% response rate to this therapy. KRAS mutational status is a very good indicator of response and predictor of response, and is strongly correlated with clinical benefit for these anti-EGFR monoclonal antibodies. So mutations for KRAS should be evaluated for all metastatic colorectal cancer patients considered for anti-EGFR monoclonal antibody therapy. So again, bringing it back to the case, KG's tumor was positive for the KRAS mutation. This patient is unlikely to benefit, therefore, with EGFR therapy, and some of the data shows may possibly do worse. So I think the general consensus is that this patient should not receive therapy with any regimen that contains either cetuximab or panitumumab. So let's move on to the final example within the solid tumor section, and I think probably one of the most controversial areas within solid tumor pharmacogenomics, and that's the issue of tamoxifen and CYP2D6. So JB is a 45-year-old female with a recent diagnosis of breast cancer, and she's just completed adjuvant chemotherapy and is scheduled to begin tamoxifen endocrine therapy. She's recently read, most likely on the internet, that the patient's genetics may help predict if a patient is going to respond or not to tamoxifen. And I think she heads to her local pharmacy where she gets her tamoxifen filled and asks her pharmacist if this is true. And the pharmacist states that this has not been proven yet. And so the question is, could this patient's genetics predict the efficacy of tamoxifen for the treatment of breast cancer? So many people would consider tamoxifen still as the gold standard endocrine therapy for patients with ER or PR positive breast cancer. I think there still is some controversy that exists that aromatase inhibitors may be also considered as a gold standard for endocrine therapy, but definitely do not have the track record that tamoxifen has. Tamoxifen is considered a selective estrogen receptor modulator. It's also approved for a variety of indications within breast cancer, including the metastatic setting. It's approved for adjuvant therapy, as well as breast cancer risk reduction in patients who are deemed to have a high risk of developing breast cancer. So no pharmacy lecture would be complete without a chemical structure of a drug, and we've included that here with tamoxifen. If you follow the bolded pathway, though, you can see the activation pathway for tamoxifen. And again, this is a prodrug that needs to be activated to its most active form. And so you see a pathway that goes from 3A4/5 down through CYP2D6, which leads to the most active metabolite of interest, which is endoxifen. So here you can see CYP2D6 is involved with the activation of the drug and leading to more active metabolite versus the example that we used with irinotecan, where you're really looking at a gene that inactivates the active metabolite. So I think that's an important distinction to note. So endoxifen is the most active metabolite of tamoxifen. It's most responsible for the in vivo pharmacologic activity of tamoxifen. We know from the previous slide that the formation of endoxifen is dependent on the CYP2D6 pathway. And we know from a variety of literature within and outside of oncology that CYP2D6 in general is highly polymorphic. When you look at the CYP2D6 gene, there is a large number of variations in terms of alleles that have been identified, at least 74 of them currently. When you look at the functional effect, you can see wild-type allele of star 1 results in normal enzymatic activity. There are specific alleles that are associated with a decrease in enzymatic activity, and I've listed some of those for you here. There are also alleles associated with a loss of function, including the star 3, 4, 5, and 6. Of note, there are also alleles associated with an increase in enzymatic activity. But we know that when you look across the board with all of these variations, this can lead to as much of a 200-fold effect on the drug metabolism of this agent. Now, one of the things that, for me, it makes it a little bit more difficult to interpret some of the literature that is out there is how the various studies define the various phenotypes. And by saying phenotype, I mean the clinical presentation of an individual with a particular genotype. So usually we'll break patients down into one of three phenotypes, either an extensive metabolizer, an intermediate metabolizer, and a poor metabolizer. And in general, extensive metabolizers should have the wild-type genotype of star 1, star 1. For intermediate metabolizers, you usually see heterozygous patients who may have one variant allele. And those patients who are poor metabolizers may have two variant alleles, which includes reduced function or loss of function alleles. So here I've given an example of three alleles of interest that are commonly seen in the population and that lead to reduced function of 2D6 or loss of function of 2D6. And here you have various populations as well. So you can see, in general, these alleles, depending on the allele of interest and the population of interest, are relatively common. So you can see in Caucasians, the star 4 allele, seen in about 20 to 25% of patients. In the Asian population, the star 10 allele can be seen in up to 50% of patients. In African Americans, the star 17 allele is quite common, anywhere between 10 and 43%. Not only does this emphasize the importance of looking at the frequency of various alleles in various populations, but I think it also emphasizes the importance of, when doing genotyping and doing genotyping trials, that you do a comprehensive evaluation of the different variant alleles that could exist and not just pinpointing one or two of the variant alleles of interest. Now, I think the history behind this story, again, is also interesting. And so a lot of it started simply by looking at the impact of genotype on endoxifen concentrations. And I think this can really highlight the potential clinical impact that this may make. So when you look at genotype and you look at wild-type patients, you see a mean endoxifen concentration of about 78 nanomolar. When you look at those patients who are heterozygous with one variant allele, you can see a significant reduction down to about 43 nanomolar. And finally, when you look at patients with two variant alleles, who are homozygous for the variation, you see about a 20 nanomolar concentration. So you can see how potentially, because of the significant reduction in active metabolite, this may lead to reduced clinical effect. To me, one of the most fascinating parts of this story has been traditionally how we stumbled upon this issue. And one of the things that was relatively common in the late 90s and early 2000s was the use of SSRIs to manage one of the most problematic complications associated with tamoxifen therapy, and that's hot flashes. So many people had found that SSRIs were very effective at minimizing hot flashes in patients who were receiving tamoxifen therapy, around the same time as when some of the PK data was being done looking at endoxifen concentrations. So many investigators eventually put 2 and 2 together in that some of these SSRIs were actually 2D6 inhibitors. And so what this study shows back from 2005 is the impact that drug interactions could play in terms of endoxifen concentrations. And over here on the far right, you can see patients who are homozygous for the variant allele. You can see the very low mean endoxifen concentrations. The thing that's very interesting is if you look at patients who receive paroxetine, which is a relatively potent 2D6 inhibitor, after receiving paroxetine therapy, their endoxifen concentrations really mimic those of patients who had very low or no functional CYP2D6. So I think this highlights the importance of screening for drug interactions in these patients, and I think it also proves a much bigger point in that pharmacogenomics is not the answer to everything in any of these case scenarios, in any of these examples. It really is just one more tool that we can use to help predict response, but it needs to be used in combination with everything else we already know about things that may affect a patient's response to therapy, including drug interactions. So that's all the PK data looking at active metabolite, but how does this translate into clinical outcomes? And this is a large study that was published recently in JAMA that looked at some of the most important clinical outcomes to us in terms of breast cancer patients. And this was done in early stage breast cancer patients anywhere from stage 1 to 3, did not include metastatic patients, but they broke it down by phenotype and looked at overall recurrence rate and event-free survival and all-cause mortality. And what they showed across the board is that patients who are poor metabolizers appear to do worse than patients who are either intermediate metabolizers or extensive metabolizers. You can see a systematic reduction when you go from overall recurrence rate from poor metabolizer of 24% down to intermediate metabolizer 17% to 12.4% in extensive metabolizers. You can also see a higher event-free survival event rate of 33% in the poor metabolizers versus the other genotypes. Finally, probably one of the most important things that we look at in oncology is mortality. And you can see a definite trend towards an increase in mortality, all-cause mortality, in patients who were in the poor metabolizer phenotype versus intermediate versus extensive metabolizer phenotype. So this is some pretty strong evidence showing not only that the PK data shows a difference between various phenotypes, but also our clinical outcomes may be different. And so this is just one of several examples that are out there in the literature supporting the association between CYP2D6 genotype and impacts on disease-free survival, treatment response, and also endoxifen concentrations. I've listed here just a summary of many of the trials that have been published. It seems like every month or so there's another trial coming out, really either showing the positive correlation, but also there are several trials that exist that show opposite effects or show no significant effects in the CYP2D6 variant population. Now this is 3 that have contradictory results. This set of trials specifically looked at the star 4 polymorphism, so didn't do as comprehensive as an evaluation, but definitely showed some opposite trends in terms of response rates. And I think this conflicting results really is part of what leads to the controversy in these patients, but not really the entire story that leads to the controversy. So in summary, when you look and break down based on the various outcomes that we look at, whether it be overall survival, disease recurrence, disease-free survival, when you look at overall survival, still there's limited information showing a statistically significant association with the star 4 polymorphism and overall survival, but I did highlight one trial that does show an association with all-cause mortality. Disease recurrence rate, there are studies again that show increased risk, decreased risk, or no association. And there are studies that show the association between CYP2D6 genotype and decreased disease-free survival. So again, controversial results out there. There's also some data out there looking at hot flashes and the incidence of hot flashes. And again, this is a little bit conflicting. There is some data that shows that patients who are homozygous for the star 4 polymorphism do experience hot flashes more often, although there are other reports that do not show a strong association between hot flashes and this genotype. So I think some takeaway points in terms of genotyping, again, I think it's extremely important to do a comprehensive assessment of various polymorphisms in the CYP2D6 genotype. Currently, there are no formal recommendations in the FDA or in the package insert on testing patients prior to receiving tamoxifen therapy. The FDA Advisory Committee did recommend a label update to reflect the increased risk in patients who may poorly metabolize tamoxifen, but again, there's no formal consensus on genetic testing. The other piece that I think leads to the controversy in whether or not to use this in breast cancer patients is really the question of, do we have any good therapeutic alternatives in patients? And I think when you ask this question in patients with breast cancer, you really have to break these patients up into two subpopulations, either being postmenopausal women or premenopausal women. The main reason behind this is that the alternative endocrine therapy in breast cancer would be aromatase inhibitors. And aromatase inhibitors can be used in patients who are postmenopausal, but the data with using aromatase inhibitors in patients who are premenopausal is very limited. And so when you look at postmenopausal patients, you can make the argument that if you did genotype and you saw that a patient had a reduced function or loss of function allele, that you could switch that patient to an aromatase inhibitor. Another option would be simply to do a dose increase to try and overcome that inhibition of drug metabolism or the lack of drug metabolism. In postmenopausal women, or in premenopausal women, it's a little bit less likely that we're going to have a very good alternative just because we don't have the real option of using aromatase inhibitors and have the robust data that we have in the postmenopausal setting. So I would say there really are no proven alternatives to tamoxifen. There are ways of getting around that by doing ovarian ablation and then using aromatase inhibitors, but that really puts patients into that postmenopausal category. You could go ahead and do possible dose increases in this patient population, but again, that has not been proven. I think there are several groups, though, that are trying to evaluate the possible impact of alternatives in these patient populations. I will say that most of this data is very immature and is currently ongoing. We conducted and are currently conducting a multi-site trial here at UNC and across North Carolina, where we're evaluating the impact of possibly doing a dose increase in these patients. So basically our objective is to evaluate changes in endoxifen concentrations following tamoxifen dose increases in patients either who are intermediate metabolizers or poor metabolizers. So what we're doing is patients who are established on tamoxifen for at least 4 months, we'll go ahead and do the genotype, do a tamoxifen PK collection. In a week, we'll call the patient back and tell them their genotype status. If they're an extensive metabolizer, they stay on the current commonly used dose of 20 milligrams of tamoxifen. If they're an intermediate or poor metabolizer, we'll increase their dose to 40 milligrams daily. And then 4 months after the dose increase, we'll repeat the PK collection. So Billy Irvin presented some of this data down at the San Antonio Breast Conference this past year, showing what I would consider our very early results. And what we found is you can see the breakdown in terms of population up here in terms of extensive metabolizers versus intermediate versus poor metabolizers. You can see there was a good representation. You can see baseline endoxifen concentrations significantly did correlate with metabolizer status, which is what you would expect. When you look at 4 months, you can see the change in endoxifen concentrations, particularly in the intermediate group here and in the poor metabolizer group here, which show definitely at least a trend in increasing endoxifen concentrations in both of these populations. And currently, it was statistically significant difference. Now, how all these groups relate to each other, I think, is one of the main questions, because we really wanted to see if we could provide a dose of tamoxifen that would leave an endoxifen concentration similar to the extensive metabolizers in either the intermediate or poor metabolizer group. And you can see from the initial data below in the second half of this slide that at least we made some progress. Although when you look at poor metabolizers, definitely did not look like we were very good at getting them the concentrations close to what we would see in extensive metabolizers. You did see a closer relationship after the dose increase between extensive metabolizers and intermediate metabolizers, but I think this data is way too young to really make any clinical decisions based on this, and we've probably doubled our patient sample size in the past year, so hopefully at next year's ASCO some of this data will be presented. So right now, really no hard conclusions on what we can do as alternatives for these patients, and I would still consider doing a dose increase as investigational. So going back to the case, JB had inquired if her genetics could predict response to tamoxifen. There are several trials that have demonstrated a significant correlation between CYP2D6 genotype and outcomes with tamoxifen. However, no trials have yet demonstrated clinical benefit to screening these patients for CYP2D6 in breast cancer when they're taking tamoxifen. So with that, I'll conclude. I want to thank the group at UCSD for inviting me to do this presentation and all your assistance with the development of the slides, and I guess I'll turn it back over to Kelly.
Great. Thank you, Dr. Valgus, for your presentation. At this time, we will now unmute the audience and continue with the webinar by highlighting future webinar dates and logistic information.
The conference has been unmuted.
We hope this information is helpful as you translate pharmacogenomic evidence into practice. If you have questions or comments, please email us at pharmacogenomics@ucsd.edu, or feel free to email me at kellylee@ucsd.edu, or our principal investigator, Dr. Grace Kuo. If you're interested in attending the future webinars, those future webinar dates are listed here. We completed today's Solid Tumors with Dr. Valgus. We have Cardiology 1 next month, September 21st, as well as Cardiology 2, September 23rd. We also conclude with Asthma, September 29th. Next, in October, we have 2 webinars that are scheduled with Economic Issues on October 5th and Psychiatry 1 for Depression on October 21st. We concluded the first webinar on program implementation on August 12th, and we'll also repeat the same content on Thursday, September 9th, which will discuss how to implement this pharmacogenomic education program into your schools. We just have one short information. Most of this will be discussed on the program implementation webinar, but the program implementation will be evaluated using survey tools, and all of you faculty trainers will be asked to complete a post-training survey based on your experience here during these webinars. All survey materials will be mailed to you after completion of these webinars in October. Again, we highly encourage all faculty to attend the program implementation webinar if you have not already done so. We will now turn to the audience for any questions to Dr. Valgus. You may also ask questions via chat function as well.
Yes, hi, I have a question. This is John Romaldi from the University of Mississippi. Regarding tamoxifan's metabolism, it seems like the data that you presented, you may never be able to increase endoxifen levels irrespective of how much tamoxifen you give because of the CYP2D6 issue. Has anyone looked at the other metabolic pathway in regard to tamoxifen metabolism? Like, for example, the 3A4 pathway. And can you give an inducer of 3A4 to sort of promote that pathway in poor metabolizer phenotypes of 2D6?
Yeah, I think that's a great question. And to my knowledge, I do not know of anyone currently who is working to induce other pathways to overcome the whole 2D6 issue. But I think that's definitely a legitimate idea because when you look at that data, when we increase the dose of tamoxifen in that patient population, we're definitely not even close to where we need to be. So I think people do need to start thinking about alternative pathways, alternative ways to do that in order to really overcome that resistance to accumulating active endoxifen concentrations.
Thank you.
Any additional questions?
This is Todd Thompson from the University of New Mexico. Can I ask a question now?
Yes.
This just is probably going to express my ignorance as not being a clinician, but I expect that at some point my students will ask, and I should probably know the answer. Relative to the tamoxifen issue, in the instance where somebody does have variants of inactive 2D6, why would you not support trying raloxifene as opposed to boosting a dose of tamoxifen or some other strategy like that?
Yeah, so raloxifene, and actually that brings up one point that I didn't mention in the presentation. Raloxifene is mainly used in the prevention of breast cancer, really has a limited role in the actual treatment of breast cancer. But if you look back to that slide of that included like the 10 different trials in terms of response, there actually on the very end there was a prevention trial. And what that trial showed is that patients who had the alternative, if we can go back here, let me, yeah, that's the one. So this very last trial is a prevention trial, and that's why I put it at the bottom. But what they found is that poor metabolizers had increased risk of breast cancer, which is, if you believe that it's significant in breast cancer treatment, then you would think that it would also be significant in prevention. Now, raloxifene, based on a very large clinical trial comparing tamoxifen and raloxifene, would say would be an alternative tamoxifen for the prevention of breast cancer, but still not an option when you're actually treating breast cancer.
Okay, good. Thank you very much.
No problem.
Any other questions from the audience?
This is Ann Mardiege from George Mason University.
Yes.
My question is that they know a lot about the CYP2D6 and how it works in other drugs. And they are accumulating knowledge on pharmacogenomics. Is there any study that looks at providers and pharmacists doing family history and personal history of medication experiences to predict what their phenotype is prior to genotyping?
So looking back to see if they had a family history of someone having a poor reaction or poor response to a drug.
Or a personal history. I mean,
Yeah.
like if you know that they had problems with antidepressants and things like that, that might give you some indicator about other drug responses.
Yeah, no, that's a great point, because I'm not aware of anyone within pharmacy or elsewhere who is routinely doing that type of screening to help predict if someone would have an issue with their medication regimen, if it was, for example, tamoxifen. It makes sense because many of these polymorphisms are inherited, and so if you had a relative who had an increased risk, a direct relative who had an increased, say, incidence of hot flashes, or I should probably say it a different way, a patient who had no hot flashes with tamoxifen and they had a very poor response, and later down the line that offspring develops breast cancer and are about to receive tamoxifen. I think that's legitimate information.
Sure.
But there's definitely, as far as I've seen, no one who's doing that screening. One of the things that we did is we actually have thought about developing a tool that would screen all patients up front who come into the cancer hospital for what we would consider very common things that we may be able to use, but other things that we would not even use. And so even before a patient begins any therapy, we would know what their genotype is more proactively. And some people even argued, and this is more extreme, but that we should be adding this to the prenatal screening that we do and add pharmacogenetic testing to try and predict down the line if someone would have any issues with any drugs that may go through these pathways. And that's something that people are actively researching, whether or not that would be acceptable to do. But I don't know of anyone who's looking back and using that medication history, family history, to make a decision whether or not they should genotype a person. But I think it's a legitimate thing to do.
Mm-hmm. Thank you.
Yeah.
Any other questions from the audience?
Yes. Can I ask a question?
Yes.
Yes. Here is Dr. Landry Camden from Harding University.
Yes.
I do have more of a practical question. How do we explain to pharmacy students how to apply this knowledge in a pharmacy setting? For instance, we are dealing here with 3 cases. In the case of the KRAS mutation, the ASCO states that patients should not take the medication. But in other cases, basically it is controversial. So how do we teach them how to use this knowledge and implement it in a pharmacy setting? Thank you.
Yeah, I think that's the million-dollar question. I think a lot of us are trying to figure out. I think for pharmacy students, first and foremost, we need to get them familiar with what pharmacogenomics is. I think that still is a huge barrier. And as I travel around to different schools in different areas within the country, I can still see that that's not happening universally. And so I think developing just a literacy of pharmacogenomics and what it is, when you break down that barrier, that I think is probably the most important piece. I think the next step really is to show them some of this data so that when pharmacists are thinking, okay, a patient comes in, is getting a certain medication, I need to think about renal function, I need to think about hepatic function, I need to look at drug interactions. I think people do have to think about genetics and think about if there's anything that's out there that is strong enough to say that you may need to test a patient. And I think what we're going to see more commonly is patients who directly go to their pharmacists and ask these types of questions. Now we have some very well-known people here at UNC, but we've had some patients who come to us, schedule an appointment with one of our geneticists with genotype in hand, list of medications in hand, and say, please tell me what I need to do or what I don't need to do. And I think as a pharmacist, what we'll need to provide students with the tools is able to look at the literature, evaluate quickly what's out there, and at least be able to tell patients whether or not this should or should not influence therapy, or if it's just too controversial to say right now. And I think that's an important piece. The example I used in here was a patient who comes to their pharmacist asking about tamoxifen, and basically the pharmacist said that the data is conflicting and we really don't know what to do. But I think that I don't know, but having that based on actual information is extremely important versus, I've never heard of that, or pharmacogen what, and you'll often hear people not even know what pharmacogenetics is. And so I think those are the barriers we need to do. Now, early on, I first started doing things with pharmacogenetics about 10 years ago. And for me, back then, it was much easier to keep track of all the different examples within oncology and outside of oncology. Today, with all the information coming out, it's really hard to be an expert in pharmacogenomics. I couldn't give you a presentation on what's going on in the psych world or the cardiovascular world, so I think it's also important for pharmacists who are going to work in certain specialty areas to at least know the data within their specialties.
Thank you.
We also have a question. Is one audience attendee asked, is the primary benefit of KRAS information to cut therapy costs as compared to patient outcomes, since those with known mutations presumably will not get monoclonal antibody therapy?
Yeah, I think when you look at the ASCO recommendations, those recommendations are based on clinical outcomes. And I think that's important to differentiate, because all the data clearly shows that these patients really do not benefit from anti-EGFR therapy. We also know that although anti-EGFR therapy may have less toxicity than some of our other traditional chemotherapy agents, it definitely comes with toxicities. These patients could have pretty severe infusion reactions. A lot of these patients develop a very nasty acneiform rash, which impacts patients' quality of life. So when you have a situation where you're not getting any clinical benefit, but these patients may develop some of the toxicities, I think from a clinical standpoint, it's clear cut. Now, it definitely doesn't help, or it doesn't hurt, that these drugs cost tens of thousands of dollars, and I think that's important to think about. But most of this data, in my opinion, is based on the clinical data, not the economic data.
Great, thank you. Any other questions from the audience? We're also taking questions by chat as well. So, okay, if there are no additional questions, we'd like to thank all attendees and Dr. Valgus for the presentation. If questions arise in the future, please contact us at pharmacogenomics@ucsd.edu or visit our website at pharmacogenomics.ucsd.edu. Thank you very much. This ends the webinar session today.
Thank you.
Thank you.
Thank you.
Thanks.
Thank you. Please stand by.